presentation, I will attempt to cover most of the information regarding Vasa Praevia, when to suspect them, how to recognize them, and what to do when one has been detected. Vasa Praevia are fetal vessels crossing or running in close proximity to the inner cervical os. These vessels course within the membranes and are at risk of disruption when the supporting membranes rupture. Vasa is the plural of vas, which comes from a Latin word denoting a vessel or a dish, thus the word vase. Praevia is a combination of two words, pre or pre, meaning before, and via, meaning way. Praevia in medicine usually refers to anything obstructing the passage in childbirth. Lobstein reported the first case of a ruptured Vasa Praevia in 1801. Before ultrasound became common practice, the diagnosis of Vasa Praevia was often made too late on the triad of ruptured membranes, dark painless vaginal bleeding, fetal bleeding, Benckiser's hemorrhage, and fetal distress or demise. The first ultrasound description of Vasa Praevia dates back to 1987. The largest studies report a prevalence of 1.5 to 4 in 10,000. Older numbers are based on less reliable data and should probably be abandoned. About 10% of Vasa Praevia occurs in twins, yet, even in careful studies, the diagnosis of Vasa Praevia is easy to miss, even postnatally, and thus likely to be underreported. It is likely that the condition is more common than generally thought. The two main causes of Vasa Praevia are velamentous insertions, 25 to 62%, and vessels crossing between lobes of the placenta, such as in succensurate or bilobated placentas, 33 to 75%. Less commonly, a vessel that courses over the edge of a marginal placenta or a placenta praevia may become a Vasa Praevia after extension of the placenta over a better vascularized area, trophotropism, and involution of the cotyledons that were praevia. To demonstrate the next views, let us imagine a uterus viewed from the fundus. After suppressing the fetus, we can look down the uterus to the inner cervix. This is a view of the inner os from inside the uterus. Let us start with velamentous insertion. Here we have a posterior placenta, and please note that I have only drawn one umbilical artery. There should of course be two, but I am hiding my laziness behind the simple excuse that too many vessels would clutter the drawings. Let's now add an umbilical vein. Then a membrane to cover all these. I am not a great artist, but I wanted to convey that 1. The vessels are in the membranes, like in a veil, thus the name for velamentous, and 2. That the velamentous complex is adherent to the uterine wall. At 10 o'clock, one can see a sharp turn in the vessels. This is where the free umbilical cord starts. Finally, note how some vessels cross over the inner os. Let's now review the multi-lobe placenta, such as the succensurate or bilobated and more rare versions. In all forms, the main body body of the placenta is connected by vessels to the accessory lobes. Note that in some cases the accessory lobes may be connected by vessels that cross over the inner cervical os. In cases of marginal placenta, a vessel may sometimes be on the edge of the inner os, supported by the placenta. But as the placenta moves away, vessels that used to be supported progressively are left in a simple membranous environment and may become previa too. Risk factors include conditions associated with vessels that run close to the cervix, such as low-lying placenta, placenta previa, multiple pregnancies, and of course multi-lobated placenta and velamentous insertions. Velamentous insertions occur in about 1% of singleton pregnancies and 10% in multifetal pregnancies. Approximately 2% of velamentous insertions are associated with Vasa Praevia. Placenta membranacea is also a risk factor. It is less clear why, but in vitro fertilization increases the risk of Vasa Praevia, about 1 in 300 pregnancies. Many of these conditions present with vaginal bleeding, which should be considered as a possible alert symptom for Vasa Praevia. The detection of Vasa Praevia can be made either by abdominal scan or by transvaginal scan. This is the placenta. Note, this patient had a placenta membranacea that covers the whole back and fundal aspect of the uterus and extends all the way to the cervix. This is the cervix, and the arrows point to the Vasa Praevia. Although a Vasa Praevia can be recognized in grayscale as linear structures in front of the inner os, the diagnosis is often very difficult to recognize, especially when parasagittal sections are obtained. The diagnosis is considerably simpler by putting a flash of color Doppler, color or power I don't distinguish in this presentation, over the cervix. A marginal placenta with a vessel that is at risk of becoming previa when the placenta recedes. Note how silent the vessel is in grayscale. Thus there is no logical rationale to not do a flash of colour in all transvaginal examinations of second and third trimester pregnancies. Compared to the previous case, this placenta is a little further away from the inner cervical os. I cannot really see any evidence of a vessel. But with colour, it is quite evident. When the fetus is away from the cervix, the diagnosis is also quite clear in the abdominal view. Since a view of the cervix is part of all standard second trimester examinations, there is again no rationale for not putting a flash of colour over the inner os. Should there ever be a doubt, dropping a pulsed wave Doppler sample over the vessel easily clarifies the situation. Here we clearly have an arterial flow, and we know it's fetal since the distance between two peak systolic velocities is very close to two small ticks on the timescale, thus 2 times 200 milliseconds. If Pulsations occur every 400 milliseconds. The heartbeat is 150 beats per minute, and thus fetal. Of course, the direction of the flow also tells us that the Vasa Praevia is crossing from the posterior to the anterior aspect of the inner os, and that the free cord will have an anterior velamentous attachment. Another simple detection on a routine examination. Click the right pointing middle arrow to start the video clip. Note that on grayscale there is no evidence of Vasa Praevia, but as the clip progresses to colour, then power Doppler, it is clear that there is a Vasa Praevia. Again, there was no reason not to use colour during this examination. The diagnosis would have been missed otherwise. As in the case 2 screens ago, this is an artery with an anterior velamentous insertion. Click the right pointing middle arrow to start the video clip. This is a 360-degree rotation of another case of Vasa Praevia. The 2D images are elsewhere in the presentation. Aside from the intrinsic beauty of the image, I am not convinced yet that I can find details that I could not find in 2D. However, clearly 3D volumes allow us to review the case, mostly in the multi-planar views, and this is a very important educational aspect. A few images now to compare the various etiology of Vasa Praevia. This is a clear image of a velamentous insertion with the vessels coursing just in the membranes. In this sequence of images, note the position of the free cord moves significantly between images. Thus we have a short velamentous insertion. This fetus has a succentrate placenta. The right image is the section over the inner os, and the Vasa Praevia is clearly visible. Click the right pointing middle arrow to start the video clip. On the 4 segments of this video clip, note 1. The succentrate lobe, 2. The cord insertion close to the edge of one of the lobes, and 3. The Vasa Praevia in colour. Another bilobated placenta. The top left image is an abdominal scan. The top right is a transvaginal scan. Note the cord between the 2 lobes. It should not be confused with a Vasa Praevia. The bottom left image demonstrates the cord, while the bottom right clearly shows the Vasa Praevia. Finally, the finger of Francois points at the many vessels interposed between the 2 lobes. With a good retrospectoscope, one can see some possible evidence of a Vasa Praevia on this abdominal grayscale image. This transvaginal image has a more suspicious image of Vasa Praevia in grayscale, easily confirmed in colour. Note that this is one of very few anterior placenta with a Vasa Praevia in my collection. This makes me fear that I might have missed several Vasa Praevia when the placenta was anterior. Let's now look at some pitfalls and artifacts. Although the diagnosis of Vasa Praevia appears straightforward, the diagnosis of cord insertion by the abdominal approach is not always feasible in obese patients, those with scars or even simply difficult fetal presentations. In cases where the inner os is not seen on abdominal scans, a transvaginal examination would be recommended. A vessel seen during a first trimester transvaginal scan should not be assumed to represent a Vasa Praevia. Too often the vessel will be of maternal origin and confused because of lateral resolution issues. Pulse Doppler will demonstrate a maternal pulse. Note that in these images the size of the fetal chest is approximately 10 weeks. The diagnosis of Vasa Praevia is thus best made in the second or third trimester. This case mimics a Vasa Praevia, a little structure that looks like the cross-section through a vessel but has no Doppler signal. This is just a small amniotic fold. This image in grayscale suggests some low-level echoes in front of the inner os. Color Doppler demonstrates bidirectional flow. Motion artifacts can occasionally give the impression on transvaginal color Doppler of Praevia flow, simply due to the sloshing of amniotic fluid resulting from fetal motion. This artifact can be recognized by its irregular nature and its lack of reproducibility. Click the right-pointing middle arrow to start the video clip. In this video clip, you can see flashes of colour, marked by a red arrow. Notice how irregular they are, not only in duration, but interval. Another pitfall is to confuse a funic presentation for a Vasa Praevia. These are differentiated by the shifting in position of the cord. If the cord does not move, just gently tap over the area. The differential diagnosis of linear structures in front of the inner os in grayscale may also represent marginal placental sinus, chorioamniotic separation, and simple folds of the membranes. The differential diagnosis of those is easily established by color Doppler. Sometimes marginal placental sinus may present with flow, but it will be a maternal heart frequency. Other diagnostic procedures include digital palpation of the Vasa Praevia itself, amnioscopy, and Agita or similar tests, which are fetal blood detection tests, and palpation. These mostly have a historical significance. MRI has also been suggested. All these methods require a greater expertise than color Doppler, and thus cannot compare in speed and availability. The improvement in outcome depends on the ability to recognize the predisposing factors. Thus we propose the following algorithm. During the second trimester examination or later examination, if the previous information is missing, observation of the placental cord insertion and the lower margin of the placenta shows that they are both clearly far from the inner os. In those cases, there is essentially no risk of Vasa Praevia, and no further assessment for Vasa Praevia is required. Or, if during the exam, ace-accentrate or multilobate placenta, filamentous insertion, a multifetal pregnancy, a low placenta or an in vitro fertilization is found or exists, then an abdominal scan of the cervix with color Doppler is suggested. If it is clearly normal, then we go back to the no-risk category. However, if the examination is not obviously normal, then a transvaginal color Doppler should be performed. If it is normal, we go back to the no or low risk category. If the transvaginal color Doppler is suspicious or abnormal, then manage the patient as having a Vasa Praevia. If during the initial abdominal examination there is any additional reason for the performing of a transvaginal examination, then perform one. If it is strictly normal, the matter can be dropped, otherwise manage the patient as having a Vasa Praevia. This should cover most clinical situations, but exceptions are bound to happen, and these should be judged as they arise. The various reported associated anomalies are probably coincidental and include cephalocele, scimitar syndrome, and trisomy 21. A few others can be related to compression or damage of the vessels by the presenting parts and include heart rate anomalies, small for gestational age, intraventricular hemorrhage in a twin, or even intrauterine fetal death. The major complication from Vasa Praevia is the rupture of vessels carrying fetal blood. This occurs at or near delivery if the condition is undetected. This results in a perinatal mortality that is overall of 36%, but if undetected rises to 56%, while if detected prenatally drops to 3%. The median APGAR score at 1 and 5 minutes is only 1 and 4 for survivors of undetected cases, yet it is 8 and 9 when detected prenatally. Further, transfusion is required in 58% of newborns without prenatal diagnosis, versus only 3% of those diagnosed prenatally. A less well quantified complication is the compression of the Vasa Praevia by the presenting part, resulting in decreased flow to the fetus and possibly hypoxia. Postnatal complications are related either to prematurity, due to early caesarean section with no confirmation of lung maturity, and include hyaline membrane disease, bronchopulmonary dysplasia, transient tachypnea, and respiratory distress syndrome, etc., etc. Or they relate to partial insanguination and complications related to anemia, hypovolemic shock, or complications of transfusions. There is no known increased recurrence risk. The authors express their gratitude to the work of Darren and Natalie Samat of UKVP Raising Awareness and of the work of the International Vasa Praevia Foundation, and our thanks to Dr. Yinka Oyelisi for reviewing this presentation. Management. The outcome is markedly improved, 96% survival versus 44%, when a prenatal diagnosis with possible corticosteroids to improve lung maturity is followed by an elective caesarean section performed at 35 weeks, or earlier if signs of labour or membrane rupture occurs. Some have advocated hospitalization from 30 to 32 weeks with corticosteroids steroids to assist in the promotion of lung maturity when the cervix is not demonstrated to be long and closed. When time permits, an amniocentesis to assess lung maturity is justified. Although there are no large-scale prospective studies to support these conclusions, personal experiences, case reports and smaller studies all concur to demonstrate a marked improvement in outcome when Vasa Praevia is detected prenatally. The obvious conclusion, until proven otherwise, is that a substantial improvement in outcome will depend only on prenatal detection. This implies a greater awareness of the condition and an effort at detecting it. Therefore, the purpose of this presentation is to help alert those who carry out prenatal examinations that Vasa Praevia are not difficult to recognize when sought, and that they are common enough to be worth seeking. In this presentation, we have reviewed many aspects about Vasa Praevia, when they may be present, how to diagnose them, and how to manage them. But we have not covered the most fundamental aspect. We have not reviewed the most important, the reason we do these examinations, the reason we practice medicine, which is to save little lives. This presentation is dedicated to the memory of Henry Cameron Samet, and to the tireless efforts of his parents, Darren and Natalie Samet, with all my appreciation for making me aware of the human aspect of Vasa Praevia. Thank you very much for your attention.